Alex. Good morning, all. So I'm standing here. Prof. Zani was supposed to do this presentation, but he's in Ukraine right now. Thank you, Palan. I think I saw Palan at IAS. I was not at IAS, and somehow I think Alex Group or the communications team had developed some kind of communication, how we can be able to access things at IAS. And so I happened to check on Edwin Sivanda's talk, and he asked a question. And then that time I was about to travel to Myanmar. And on our HCV program, we were looking for money to extend to Kachin, trying to help an organization called HRN. Yeah. And I used Palan to reach out to Global Fund in Myanmar. And we had discussions and found a small amount of money to help out. So it's glad that I can see you face to face. Small world, right? So I think I need to say something little about myself. How do I change the slides? I'm clicking next, and oh, beautiful. So that's my outline. Okay. Technology. Thank you. So I'm from Malawi, and I don't think I was exposed to hepatitis C in any way, but in the early 2000s, I had a friend. So that's when I came to the realities of the effects of hepatitis. He had liver disease and somehow enlarged abdomen, and when they examined him at the hospital, it was hepatoma, hepatocellular carcinoma, liver disease. And within 3 weeks, he died. I became interested to know why and what is the problem. And so I came to discover that he had hepatitis B. He was HIV negative. And then eventually, I was working in a cohort of women that were on antiretroviral drugs and trying to intervene transmission of HIV. And I decided to analyze some specimens together with CDC in Atlanta to look at hepatitis B and C in mothers and their infants. Then my interest still developed now looking at more liver disease aspects, looking at other issues related to liver disease. And one of the issues in Malawi was to do with blood transfusion. So I started working with the Malawi blood transfusion in trying to find ways in how we can optimize our diagnosis, given the fact that hepatitis C in the population has low incidence in our region, except in high-risk groups. So in that case, there was need to, our diagnosis for hepatitis C was a bit difficult, and therefore the kind of reagents available would lead to some mislabeling of people. And so that's why there was need to find some ways of diagnosing. That's how I came into the field. And then eventually, 2 years ago, 2 years now, when I joined Right to Care, they asked me to oversee Ukraine and Miami HCV program. I think this knowledge is common to all of us, that we have about 185 million people worldwide infected with HCV, and that we expect that more than 50% of them, if untreated, they would develop chronic liver disease, and eventually 25% of them would die. And for those that would have HIV, the problem will be there will be more progression, and the dying will be even more faster. So WHO has got a strategy with targets for 2030 with making sure that we make a diagnosis of 90% and treat 80%, and so that we can reduce mortality with 65%. And therefore, it's our obligation that we put in more resources to make sure that we reduce mortality related to liver disease. So regarding Myanmar and Ukraine, I think the data is that in the general population, you have prevalence of HCV of 2.7%. But then if you look now in terms of the high-risk groups like PWIDs, the prevalence is much, much higher. And so you would get people that are PWIDs to have 60 to 90% prevalence of HCV. And this happened to be a population that will also be at risk of HIV. And the numbers are almost the same in Ukraine, with 5% HCV prevalence in the general population, giving about 2 million people. And the risk, I don't need to repeat that it's more amongst the PWI population. So Right to Care is a solution-based organization. We want to find solutions using some innovations. I think the word right means access. So you want to make sure that many people have got access to treatment and care. And so the challenges in terms of HCV and the population that is affected is that there's lack of adequate facilities for diagnosis and treatment, free to clients. And most of these population cannot access treatment because they are of low income and there's stigma and discrimination, government clinics, and fear of prosecution. Like in Miami, for example, especially in the north, the populations that are PWI are mobile because they tend to run away from criminalization, and so therefore they are hard to reach. So another problem is that the drugs themselves are expensive, and there's high cost of laboratory diagnosis. And so basically, I think there are three things that you can see from this slide. Number one is the population itself at risk, the vulnerability of that population. Number two, the drugs. The cost of the drugs is quite high. Number three, it's laboratory. It's quite expensive. And so maybe I should say number four, in terms of the population itself, where the population would be found, most population would be found. Like in Miami, they'll be in the north, so geographically difficult to reach, poor resourced, and so difficult to reach them. So therefore, they do have interrupted electricity, and the laboratories themselves are poor resourced. And so because of that, we are Right to Care with funds from USAID. We decided to go in there, in both Ukraine and Myanmar, basically to target those things, to reach out that population, number one. Number two, to test, find ways of how we can be able to deliver treatment to this hard-to-reach population using low-cost lab, but also with negotiated cost of drugs. And we designed the project in 2 phases. So the first phase was just trying to demonstrate that it's possible. And the second phase was upscale. And so the first phase, our target size is 800. And we are done, surely. So these two countries, I mean, just going into regulation, are countries where there is quite restriction. And therefore, one of the problems is the people themselves that are PWITs, they would have limited access to opiate substitutional therapy. And therefore, that drives HIV infection and death. So one of the things was demand creation in trying to deal with stigma and bringing some continuous medical education to government medical officers. In the two countries, the drugs that we use are different. In Ukraine, we are using Havoni, which we negotiated with Gilead. In Myanmar, we are using Eclipsa, which we purchased from Merlin and negotiated some price. And all people that were eligible to get onto treatment stayed on a course of 12 weeks and thereafter assessed in 24 weeks. So we made it a minimal follow-up kind of program. So where at baseline we did all the labs to make sure that we get the right people and follow them up, and only did another viral load testing to check whether they have been cured or not at 24 weeks. So that data is still coming in. So that's the flow, basically. I think I've talked about it. We screen for hepatitis B, we enroll and link them to treatment. In Ukraine, they do have community-based organizations that would help in recruiting. I really like the system because as part of the team, you also have the social worker support. And that when the physician is consulting with the patients, they have a social worker who eventually helps in follow-up and providing for adherence. And possibly, eventually, if there is any problem, they can help in counseling. So in terms of drugs, when we negotiated with Gilead, it was quite a process. And at a point, wondered whether it was going to be possible. But we managed to get a 2+1 where Gilead charged $300 per bottle and said, for each bottle we give you one, and therefore reducing the price to $200 per bottle. And totaling a cost of $600 for a 12-week course per each patient. In Myanmar, Milan gave us $185 per bottle. There are no initiatives in Myanmar in terms of government initiatives for reduction of the price, from what I know now. But in Ukraine, I think there are government initiatives to bring down the price. I think they have negotiated down to almost $89 per bottle. For other drugs being provided in both countries by government and other treatment programs are donor funded, one of them can be Global Fund. In Myanmar, the first line of drugs, there would be some interactions, and therefore DTG was used, and it was also a journey to really have that drug placed on as one of the regimes in their policy guidelines, in their treatment guidelines. It was quite difficult, but eventually it happened. So adverse monitoring, for those that would have ribavirin as an additional drug, needed monitoring of hemoglobin, and for those that maybe would be co-infected with hepatitis B, they would need tenofovir and therefore need for monitoring kidneys. But in our experience, I think there were a few people that had problems, and there were no dropouts at all. Data management, we used Hepatic, what we call Hepatic, which was provided by one of our collaborators, ABLO, and so Hepatic would help to capture the data as well as provide a dashboard in terms of real time you can be able to check in terms of what is going on. Okay, so maybe I really did quite a breakdown of age, but you see that I think amongst the patients that we dealt with, it was most of them would be above 30 up to 50 plus. The gender-wise, most male, not most male. 751 was the A, not necessarily. So there, we check. Yeah, most male, and then female less, and then you have a transgender that was only one. I can't see on my thing because there's something blocking. So our classification in terms of PWI, I think the data still needs to be cleaned, but you'd see that we have almost more than 50% of PWI population. In Mandalay and Yangon, the PWI population is less, but in Kachin, in the north, you'd have more PWI, and that's where we are now in trying to continue follow-up of our patients. In terms of genotype, I think it's GT6 and GT3, which is common, but you see we are using a panogenotypic CLUPSA, where you don't need to add ribavirin. At first, we were adding ribavirin, but we dropped it out, and we just treat. I think that's the better way, because at least you reduce the number of follow-ups that you need to make for hemoglobin monitoring. GT4 that you see here is something that they have seen for the first time, and they need to verify that. So in terms of comparing testing mechanism, because the interest really was looking at conventional labs versus those where you can be able to test in rural areas like hard to reach, so using GeneXpert versus Roche and any other method that is central. So we saw that GeneXpert and Roche, I mean, they was the same, so there was no problems. And so therefore, we said, let's continue and go ahead and use GeneXpert without necessarily using any kind of central lab testing. In Ukraine, we have been using like a private-public kind of approach where patients would get some coupon from Global Fund, and then we pay the 50% in terms of testing. So this just shows the numbers. So far, the target, I said 800, screened and consented 934, and so far we have assessed 298, and we're still having. And for those that we have assessed, we know that we have had 98% achieved, and about 5 failures, and so we need to know what's the problem. Ukraine, similarly, we for those that we have assessed for cure, so far 104 and only 1 failure, so that's really great in terms of success. I just want to rush and talk in terms of lessons, because I think the issue here is making sure that what is it that we can learn and be able to use in South Africa. One of the things that I've learned is collaborating and implementing partners. In Myanmar, for example, we had Ministry of Health, National AIDS Program, and implementers like Liver Foundation, HRN, and other partners. Labs, a private lab, and Department of Medical Research Lab. So if you want to deliver a protocol or any change to the protocol required consensus of all these partners and at times really delayed the process. So any major decision really required a lot of consultations. And some of the delays were because of some, I would say, personal interest. In Myanmar, the scenario is that, you provide, so they do have some NGOs, non-NGOs, and so you are not providing funding direct to the government health facilities. You have to pass through some kind of NGO that will work with community-based organizations, and therefore you can see the trickling of the money. And eventually, when the money is reaching the clinic, is much less. So one of the challenges is the regulatory framework for supply and chain management. And so in Myanmar, if you want to import products or drugs, the process can take more than 2 months. And so it means that you need more time for planning. And for Ukraine, there is need to register if it's any kind of, whether it's a software, some drugs, there is need to ask for import permit, which is done once, or else another thing is you made to make sure that possibly you work with an NGO that can ask for humanitarian aid. So it needs to come in as donation. And it can be complicated and so frustrating. Poor infrastructure and limited resources, I think I've already said about Myanmar, interrupted power supply, few infectious disease specialists to manage co-infections, and you see you are working with hepatologists who are interested in the liver, and they may not be interested in people with HIV, HCV co-infection, and that can be a problem. So similarly, in government, as I've already said, they have few resources, and therefore money will be with the NGOs, and this leads to some problems in human resource capacity. Harm reduction programs, the harm reduction program or opiate substitution therapy quite advanced in Ukraine and Myanmar. And so in Ukraine, they will use community-based organizations. I've had opportunities actually to go out and see how it's done. And so they would do testing and screening out there, but also be able to interact with clients. I've already talked about use of social networks and having a social worker with the team in terms of our treatment delivery. So these are some of the things that I thought that there would be shifts, support for test and start, including rapid rollout, capacity readiness assessment, and costing. So one of the things that we'll do is to make sure that we come up with a well-costed strategy for elimination of hepatitis C in both countries. A simplified model of with minimal costs in terms of even follow-up of the patients throughout the course of treatment, and use of GeneXpert as POCT. Some treatment approaches, use of community-based organizations and distribution of drugs using those community-based networks, linkage to treatment facility for HCV, HIV confirmation in case of positive from the community itself, and the immediate initiation of HCV treatment among key populations. I think those are things to learn from. Parallels, is it doable in South Africa? Infrastructure, relatively good infrastructure. If on first evaluation, I've been in South Africa, and I've visited Myanmar. Human resources, South Africa has got a high number of infectious disease specialists, internationally renowned for managing HIV and co-infections, so it's possible. Treatment and care delivery, highly successful RIT program deliver a good platform for integrated HCV, HIV. Maybe, I don't know the scenario of inclusion of social workers. I'm not sure how we use our social workers, but I think it's something to consider. Towards elimination of HIV, HCV, I think HIV will drive HCV, but also provision HCV treatment is an entry to empty the port of the epidemic in South Africa. I think we can collaborate with PAMA and make it happen. Thank you.